I'd like to begin by acknowledging the traditional owners of the land in which we meet, the Gadigal people of the Eora Nation. I pay my respect to elders past and present, and to the children of today who are the elders of the future. So thanks for coming along. We're in for a pretty interesting afternoon, I think. What we're going to do is have a series of presentations, and the whole purpose of this is really to pull together a community that would be in a position to have established collaborations in the future, so as challenges are presented, and there is funding that becomes available for research in these areas, that together as a group we're well positioned to do that and to put things forward. And there's been some preliminary discussions around a possible cooperative research centre in areas like this, but as you know, there's other funding mechanisms by which we can tackle some of these challenges in front of us. So without any further ado, I'll introduce Professor Stephen Moore, who's going to kick us off. Thanks, Stephen.
Hi guys, I don't think I really know anybody.
Do you want us to run around the
that's okay, we will.
Yeah.
Okay, so my name is Stephen Moore. Just to give you a little bit of background. So I'm currently at Central Queensland University up in Northampton. Don't worry, I didn't hear it before I applied to go there. I've spent most of my career working doing research with NASA. So I did my PhD at RPA in Sydney in the vestibular lab with, I don't know, I'm arguing here because all these names mean anything anymore, but there were definitely some big players in that vestibular field. Did my postdoc at Mount Sinai in New York City with Bernie Cohen, who was one of the big vestibular guys. And I started working on a MEA and shuttle projects, so short duration projects to start off with. We flew 1G short arm centrifuge on the shuttle, so I think we were the first people that actually tried artificial gravity in space, so 20-minute 1G exposures, and we did find some protective effect for overlap reflexes. Once I get this talk, I'll talk a little bit more about that. So after 20 odd years in New York, I got sick of being on the soft money treadmill, so then I came back to a relatively safe residence. I'm now director of the AI Centre there because it's not my area of expertise, but I'm learning. So just to set the stage, so most all of our research has come from either relatively short-term shuttle Soyuz flights or space station, and longest is some guys have stayed up there for a year. But I think if there was anything non-emergency on the space station, they'd certainly recommend come back. There's always a Soyuz there ready to be back in well less than 24 hours if they had to. But if they go to Mars on current technology, you've got 9 months there, 9 months back, however long you spend on the surface, but it really depends on the sort of relative location of the planets in the orbits. So 3 years, essentially, I think is probably the sort of window to think of in terms of exploration class mission. It's not the same throughout the mission, so you launch, this is sort of Soyuz, it hits a peak of about 4G, tails off, and then the main engine cuts off back into 0G, or called microgravity just because there's always tiny perturbations. And then you have 3 to 7 days of sort of an acute adaptation phase. That's where the motion sickness and a lot of those issues come up. Most people recover typically after 3 days. Some people have been sick throughout an entire 2-week shuttle mission. But in general, can be handled, but it does have an operational impact, and some people may be too sick to carry out tasks. Then, however long the mission is, you have a much more sort of long chronic phase that's where changes to bone, muscle, and also the big one that popped up about a decade ago is the permanent vision damage from the cephalid fluid shift. Get to the end of your mission. Basically, after the adaptation phase, you're generally great because you're adapted to microgravity. You're maladapted to Earth, but the microgravity is fine. You come back hitting about 4.5 G peak, up to 9 Gs. We had one we tested, they had a 9 G. It was an uncontrolled ballistic return, so there was no retroplasmic bang. So that's the largest I've seen. But 4.5 G, that's perfectly tolerable. That you hit that on a roller coaster. And then after the return, there's a similar 3 to 7 day period where they have to recover, readapt back to terrestrial gravity. Excuse the figures, it's not my talk for the primary school kids at the STEM Academy. So cardiovascular, in the first week of space, so as soon as you go up there, you don't have the hydrostatic gradient anymore. All those sort of mechanisms that are there to push the blood up to your brain keep working, and so basically you get that 1 to 2 litres of venous fluid shift up to the head. Sorry, up to the head. And in the first 24 hours, so that the CNS obviously sees this as being, oh, I've got excess fluid, so blood volume, total blood volume drops by 10% over the first 24 hours. The other things in the acute phase, sensory motor, this is an fMRI image of my vestibular labyrinth. Space motion sickness is the most common one, almost everyone gets that. Veteran flyers, so there seems people do adapt to sort of the space flight environment and Earth, because veteran astronauts don't get motion sick as a general rule. Also, a lot of decadence in fine motor control, because you think all your motor programs are predicated on, say, your arm weighing something. So when you see the 0G, those patterns are slightly up. So, but nothing too gross. And bone, the sort of acute phase, so basically without the loading of the skeleton, and particularly without that high frequency heel strike, basically you have bone resorption, but there's not bone growth. So basically it just all goes one way. So your bone starts decreasing straight away, and that's almost immediately seen in the first 48 hours in quite high urinary and fecal calcium levels. So getting now to the chronic adaptological, this is my terminology, there's no visual terminology. So basically, you've got through that first very intense period, the cardiovascular system has reached stasis, so you've got about 10% less volume, you've got that cephalid fluid shift, but in that environment, that's fine, you're suited to a 0G environment. As it goes on, so the resorption increases, so your bone mineral density increases about 1 to 2% a month. I should put out these figures are probably about 5 years old now, so they're always trying new medications, so it may change a little bit, but the problem's still there as far as I know. And obviously with those increased calcium levels, very nasty to get a kidney stone in space. And also all the postural muscles as well, because essentially you're not using your lower body, not using the upper body like that. A lot of studies have looked at the calf muscles, so they went from 13 to 32% loss in volume and power, and transition from the type 1 postural motor fibers to type 2. So basically your body's adapting to an environment where you don't have to walk anymore, and you don't have to fight gravity to push units fluid up your head. The really big one, that's probably the biggest health priority for NASA at the moment. So about, I think it's 2009, so it's getting up to 15 years ago, a crew member coming back on the Soyuz couldn't read the checklist. And he had schizoids of missing chunks in his vision. And I was giving this talk to the Australian Space Agency, and the Canadian astronaut Bob Thirst was in front row, and he put his hand up and said, "Oh, that's me." So he's got to have a chat. That's permanent. So he has permanent visual damage. There's at least 7 astronauts I know of that have significant permanent vision damage. And that's basically from what they've gone through at least 5 acronyms that I know of. So now they've got spaceflight associated neuroocular syndrome. So all that, I'm not a clinician, so some of you probably could understand the mechanisms way better than me to explain it. But essentially all that fluid pushing up there causes swelling, changes in the shape of the orbit, damage, there's some damage to the retina through the green folds, and there's you get the basic picture. So, and some of these main changes in the shape of the eye are permanent as well. So a lot of study has been devoted to this, a lot of in-flight development of in-flight instruments for characterizing these changes. So I was starting off with ultrasound, increasingly more sophisticated. And the really big unknown, which I don't know much about at all, but I would say is probably the biggest risk that I don't see any sort of mitigation strategies at the moment is exposure to radiation. So when you're up in the space station, I think it's like 700 times the dose you have on Earth. And once we go into deep space, to go to another planet, once we leave the protective magnetosphere of the Earth, you're totally exposed to those galactic cosmic rays. There isn't, obviously they do a longitudinal study of every single astronaut that's ever been in space. It hasn't reached the level of significance, but there is definitely some evidence of increased cancer rates of definitely cataracts, especially like with high astronauts. Cataracts. And I mean like higher than normal baseline. So now we've been in space, your bones, you're losing about 1 to 2% of the bone density a month. Losing about 30% of your muscle volume, and this is in the presence of doing countermeasures like in-flight exercise. So now you return, and now it's flipped around. So when you went up, you went from 1G, peak to 4G, bang, then you're in 0G for a long time. Other way around, you're at 0G, you return, you hit 4.5G, and back on the ground, you get 1G. So with cardiovascular, so now this low volume state that's a characteristic of microgravity is known as adaptive terrestrial gravity. So not unexpectedly, astronauts experience tachycardia, and probably the most operationally significant is this pre-syncope and syncope. So they do a lot of orthostatic tilt tests post-flight, and we did some of my studies. Really depends on the statistics, because I don't know why, but people don't standardize their tilts. Some people use 60%, some people use 80%, which changes sort of the endpoint. But between 25 and 64% of first-time flyers will faint when they're presented with an orthostatic challenge within, say, an hour of landing. And then normal fluid distribution is pretty quick to recover, so within 48 hours. Sensory motor, very, very common to have head-induced motion sickness or head-induced spatial disorientation. So surveyed shuttle crew members said that 80% of them said that when they were returning, when they moved their head, it felt like the world, they tumbled. They call it tumbling the gyros. So that's basically due to the persistence of the central nervous system adapts to the lack of the zero-G input to the overlist in gravity. So, for example, when you nod your head on Earth, the semicircular canals are picking up the angular velocity, and then your overlist detect that your head is changing with respect to gravity. So, this gravity is to detect that pitch. You do the same thing in zero-G, you've got zero coming from the overlist. So, in the first week, the brain goes, what the hell, I'll throw up. And then in this recovery phase, well, there's motion sickness, but a lot of it is the spatial disorientation, which is a big operational, could be a big operational impact for landing, say, after a long flight. Even though it's most likely to be largely automated, the space program has a long history of automation not working and having to take over, so it still is a concern. Postural and gait instability is a lot of problems, especially if you ask them to stand upright with their eyes closed, stand on rails. Also, problems with gait and oscillopsia, and that's probably due to the vestibular reflex of being a bit out of whack. I'm almost done. This might be the last one. Now talking about long-term recovery, so the bone density loss, so 1 to 2% per month, so say 2% over 6 months, so 12% for a 6-month ISS mission. Most people get out 50% recovery after 9 months, and I don't know, probably at least half of them, maybe most of them, never get back to their pre-flight level. So there's orthopedic guys, if there's any. Obviously, risk of fractures in EVAs, whatever, planetary EVAs in space would be quite an issue. The muscles recover with a lot of rehab and gym work over 1 to 3 months. Probably the biggest problem I've heard them complain about is lumbar pain, lower back pain, because you think all the cartilage expands in space, so they're about 50 to 60 centimeters taller, and they come back and then they absorb the pressure again under gravity. So they have a lot of problems with their lower back. And that's meant to be L. The visual problems are caused by that sacral fluid shift, that long duration, long-term chronic pressure in the head. That's it.
Thank you. Okay, well, we'll be asking Stephen to go around the 3 groups and spend 10 minutes with each of the groups, so you'll be able to get into his mind then. So we'll hand over to Fiona.
Thanks very much. Thanks, Gordon. My break is to talk to you about healing skin in space. And what do I know about this? Well, there's not a postage stamp small enough. I've never been, and I've never done any surgery in space, so I'll just sit down. But it gave me the opportunity, like Gordon often does, to stretch my mind and think, well, okay, let's work this out, let's think about this. And for me, it gives us the opportunity to think. I've lived in surgery since I first did my first operation as a med student in the late 1970s. And, there's an element of surgical inertia that I think needs a bit of a shake now and again. And how do we shake up this juggernaut that provides a very good service? Well, it's about thinking about things differently and looking at opportunities to think differently. And I think this is one such case in point. And so I started looking, well, what the experts know about this, and so I expect you all to read this because there will be questions. Okay? But what is it that we want to understand? And there's been things done in this space and gravity research for a very long time. I mean, one piece of trivia is my youngest kid is the only Australian to win a gold medal in trampolining. And at the World Championships, that is. And so she, as a 17-year-old, did this, and she also, as a 17-year-old, did a research project on the G-forces on your brain when you do triple somersaults. And they're significant, and they used to train astronauts, on trampolines and spinning them around as in the early days. And so, there's an element of understanding that these things influence the human condition. And there's an element of understanding that the human condition is vulnerable. And so in spaceflight, we need to think about not just the physiological effects, but the health risks. And I guess that's where my mind is going. Okay, if somebody is up on the space station and there's a problem, they can get home. Probably a bit quicker than I did on the tram today, anyway. But if we're really serious about Mars and beyond, then we've got to understand what we take with in terms of resource, education, training, capability. In order to facilitate that health issue. And so the risks involved are really important in understanding. So who do you pick? What's the medical capability, the equipment, the training, and the space? How do you actually get something on that space shuttle, rocket, or whatever, I mean, on a completely different note, Ashmore Reef, 2009, April, there was an explosion on a boat off the north of WA, and there was a lot of people in the water. They dragged them over the side of the rubber dinghies, they got them to an oil rig. We accepted 24 patients, which arrived at Mount Perth 26 hours post-injury. Every single one of them infected, because our standard of practice is to put silver dressings on. The silver dressing at that point in time was the silver cream. They couldn't actually load enough silver cream to cover that many adult males onto the aircraft. So I know this happens right here, right now, in what we have to do on Earth, right? So you just expand that and you think, well, whoa, we've got to think about what it is that our resource capability is and the physical space involved. And so that brings us into looking at robotics and all sorts of interesting things. So I'm going to talk to you about sort of spitballing ideas, and I'm hoping that we're going to spitball more ideas, and then we're going to come at the end of today with some ideas that we can actually start to to work on in the collaborative sense. So we're looking at, long time. I was at primary school when they took that big step for mankind. Yeah, I was like 9. And so, it's been a long time. And during that time, our science and technology has advanced a lot. But has it advanced enough? I would put it to you no. I think I put it to you that we have a constrained thinking algorithm in our universities. I think we need to actually blow that up. We need to overcome the inertia. We need to engage in courageous thinking. Because in 60 years, if we actually thought in engaging creative thinking, we'd all be going to Mars for all of this. We're talking 60 years. Where are we? Oh, we need to get a bit of a riddle on, And so, I'm just going to take a stand where I come from, things I know, I know that skin is underrated. People ignore it. Nobody's looked at skin and the turnover in skin in space, only just recently, And I know that if you lose your skin integrity, it influences the whole of your body systems. We know this from our burns work, and we know it doesn't have to be a lot. So we know that losing skin integrity in a vulnerable environment is of serious consequence. Because right here, right now, I can tell you that there are some people's phenotype is such that when they have a relatively trivial burn injury, it will influence their malignancy risk, their cardiovascular risk, unmasked diseases of aging, and that inflammatory response and that immune response will change their lives. And why is another interesting issue that we're working on. So we know skin is really an important part of this. We know what we're facing in this. The challenges of space are time, distance, environment. And they've done a lot of risk analysis. When you look at the NASA literature, and they've got the models of the risk, and this is a bit small, but they've got skin abrasion, skin laceration, skin rash, toxic dermal exposure, burns, cellulitis. So, because that is where my medical expertise sits. The risk profile, I think, is 0.00. It's one of the lowest risk profiles.
Yes, the thing is they're driven by things that actually happen. So I don't think they've had anything serious happen.
Exactly. Yeah.
Someone gets a major burn, it'll be.
If somebody gets a major burn, there's a bigger issue, than the person with the burn. And so when you start to look at the risk profiles, these are all based, as you say, on what's happened in that sort of shorter distance, not what's happened in a longer distance when you can't actually do something about it and get back home. So we've got a low risk environment, and that's why skin is down the bottom of the pecking order, if you like. Oh gosh, that's a bit small. But we've got experience of healthcare in austere environments. The disaster responses, the Antarctic expeditions, remote WA. We have got experience that we can call upon, but we need to actually understand that is just blown into a completely different scale. And of course, complicated, what we don't have in those austere environments, Earth-based, is the gravity, microgravity, not zero, I guess, and the radiation problems, which both have profound effects on the skin. So if we look and say, what is our current practice? What are the drivers to improve? We've got the local issues, we've got the systemic issues. We know first that if you have clean, cool running water, you will reduce the injury to your skin. How are we going to do that on space? Clearly we're not. But how can you do that in an austere environment on Earth? So can we use this opportunity to develop interactive topical gels that we can print on the surface for using materials that we have in our environment, which I'll come back to, such that we change the paradigm of first aid and we then can introduce a different paradigm here. We look at initial dressings. What are we going to do? That's the example. We didn't have enough dresses to treat 20 odd people in the North Timor Sea. How are we going to do this in a space environment? We've got to actually think about it. Well, research support, again, I think when we get to that point, That's really long distance. And we need to, I don't know how many medical folks are in the room, but our resuscitation is focused on big volumes of fluid. To maintain basically circulation to solid organs, the brain, liver, heart, lungs, etc. But it doesn't address the problem. The problem is our blood vessels have become leaky as a response to the inflammation. And so all that fluid is now extracellular fluid, and we need to maintain the intravascular volume in order to maintain solid organ function. Well, wouldn't it be smarter to actually address the endothelial cell adhesion so we didn't have a problem in the first place? And certainly in the space program, we haven't got somebody coming behind with 20 litres of fluid to give Joe Blow. Where are we going to get that from? So it focuses our minds on thinking of how we actually treat the source problem, not 3 steps down the track. And that's just an example of that. Now, there's things that we could do by pulling back, looking at our knowledge around the inflammatory response at the cellular level so that we can actually then improve what we do. Wound healing, I'll come back to, and regeneration versus repair. Now, the wound healing and regeneration versus repair again is this great opportunity for us to think about things in a different way. And understanding the local and the systemic drivers gives us, again, an opportunity. For example, how am I going to skin graft in space? I've got a dermatome, I can prepare myself over here to grab, I guess, and you could take this, I'm sure we could work out how to do surgery in space. There's certainly certain protocols on the internet about an experiment on the space station about suturing ex vivo skin. I cannot find the results of that protocol, but they're clearly thinking about how you would adapt the instrumentation and all that sort of stuff. Why don't we do something completely different? You know, why don't we, in my context, seal the surface with a 3D printed solution and then stimulate the body itself, from a pharmacological perspective, to produce cells that can be then directed to the area of injury, maybe by external neurological or external electrical or internal neurological stimulation, so that the cells hone into the appropriate type and express a regenerative phenotype. So we don't need to skin graft at all. We can drive regeneration, not repair. And so then, again, improve what we do right here, right now, in the Earth. Now, plants, I think, is a really interesting part of all this. And one of my colleagues in Ryan Lister in UW is working on a grant he's got for plants in space that will produce medicines and resource materials. I think it's fascinating because I tell you, you will not heal and you will not maintain your bone density without nutrition. Fascinating as I'm listening to you. If you put a 1 centimeter burn on a mouse, your femur bone density reduces 30% within 6 weeks. That's in normal gravity. So what's going to happen in reduced gravity to this extra insult, whether it be bony, soft tissue, whatever, a surgical need of any description adds extra insult, and then we've got already a compromised space, and we know that will be further compromised with that vulnerability. So nutrition, yeah, that's a whole other area that needs interrogation, because without adequate nutrition, the vulnerability of the human, the astronaut is massive. And then we look therapeutics, I think the plants, but base materials, looking for 3D printing based materials, whether it be cellulose. Cellulose is something we use in dressings. It's with plants. You know, how do we process that cellulose that we bring in plants for the 3D printer? Cell therapies, I think, is again a really interesting thing. How can we take bank cells, make stem cells, to augment the condition? And if we do, how are we going to apply those stem cells? How are we going to expand the stem cell population that may be frozen so that then we can actually apply it to the surface? So all these things and lots of questions, just as I said at the beginning, I ain't been there. And so when we look at wound healing, and you start to look at this very complicated cascade of responses around inflammation, coagulation, inflammation, vascularization, and remodeling that we think we know about, but we're just only scratching the surface. People have looked at the cells within that, and they've seen that in the various microgravity simulation models, they can see that this actually affects at the cellular level. Well, that's no surprise, is it? Because I think it's been well known for a long time, that particularly about the bone density. Well, that's a cellular response. That's a systemic manifestation of something that's happening at a cellular level, and it's happening in the skin as well. You know, the skin turns over all the time. It turns over differentially. Your dermis is slower than your epidermis. Your epidermis in a young person is probably 6 weeks. In someone like me, it's probably, 6 months. But anyway, and so it is age related and it is capacity related. But then we have got an understanding that this is just one example of quite a big body of literature of how cells actually are influenced and which pathways, and particularly the mechanotransduction pathways. So if these pathways are influenced, how can we use that knowledge for better? How can we mitigate against secondary problems? So it's understanding that sort of pressure between those two aspects. And so, as I said, we know that there's changes related to gravity and radiation, and particularly it's been well described that there's a level of inflammatory changes with changes in cytokines, and that's been, sorry, I should have put a few references up there, and the immune responses for the returning astronauts. And I think it's interesting that they've followed over time, and that this idea that, oh, well, you come back, you get better. It is erroneous.
Like that reactivation of latent virus.
Yes, yeah, it is erroneous, yeah, because you carry this change with you for life, and that's, I guess, what I see in a burn patient. Some burn patients carry that inflammatory insult for life, and part of the astronaut selection may be looking at the phenotype who will carry that for life and the phenotype who wouldn't, for example. And so I think this is a really important understanding of how this changes, but controlling inflammation is really important if we're controlling inflammation of our life for cardiovascular disease risk right here, right now. And so the tissue changes that we see within the skin, changing over, reducing ACM, aging cell populations. One of the things about radiation and skin is, it's the eye is an obvious one, but then the skin is coming in second. What would you do if you've got an increased risk of skin cancers? How are you going to deal with that? Then you come back to suturing in space, I guess, or how can we actually treat this pharmacologically? And can we actually prevent it? And can we actually use smart surfaces over the skin or in the clothing or whatever it may be to reduce the risk of the changes to those cell populations with the radiation? Because if you look at patients who have radiotherapy, for example, and this is an area we're researching right now to understand the fibroblast in scarring, the area that's been irradiated, the fibroblast changes in a way that is different from a traditional scar fibroblast. It will never recover, and it will continue on this scar trajectory that is a different character. So if you've had head and neck cancer, and you've had your neck radiated, or breast cancer, breast radiated, and I come as a surgeon to then take a little bit of tissue because you may have a recurrence, and I try and take it out of the middle, it is doomed to failure because I can't get that to heal. So I have to replace the whole. So there's changes in those fibroblasts from irradiation that are unique to radiation changes, is what I say. But we need to understand that in order to understand how we mitigate against. And maybe what we want is just like this, This is Luke Skywalker. I'm sure you all recognize him. And this is a picture that was sent to me because I'm often saying, when Darth Vader chops his arm off, they give him a new one, and it works like a myoelectric. Well, they're available. There's a young orthopod in Sydney, isn't he, who does the also integrated myoelectrics. But when he's blown away by the stormtroopers, they put him in the back to tank. So maybe that's what we need. But how are we going to get a tank like that up there? And what's we going to put in it? And all the rest around, yeah? But maybe that regeneration rather than surgical repair is where we're at. So, I mean, that's put a lot of questions on the table. Like, what is the gold standard? And I thought, well, I put this up for where I started. This is a kid I met in 1985. Put everything together in this triangle. What does the person need to recover? What is our skills available at time of care? And what are the resources available to optimize that care and drive outcome? The carer's skills can be enhanced by, we work in digital health, don't we? We can actually communicate over time. We can provide education. We can actually upskill people. We can address those resources and how we're going to be innovative in accessing the resources. But the point of fact is, it'd be an awful lot better if we did this, regenerate, than this. Because if you're in the middle, you've got your one-way ticket to Mars, and then you end up you can't move because you're locked in scar, because the only solution has been to allow it to heal slowly and to scar up, then you're going to be a lot less helpful to the rest of the team. So regeneration, not repair, matters. And enhancing human resilience matters. I think the whole back to Earth is of interest. It may be, we don't want to be a bungee jumping lizard, but enhancing the human resilience in this whole context, it is an opportunity to do just that. But it's also an opportunity to enhance our healthcare delivery across the board. Because by learning from that austere environment and being innovative there, we will, I'm sure, learn an enormous amount. So that was my 2 minutes on this. Thank you very much.
Thank you very much. So if Fiona professes having ground zero knowledge of space, then as an orthopod, mine is sub-zero. But as I have learned from the past when hanging around Gordon's, we all got to dress alike. So I'm in a black t-shirt, but I still remain the imposter. I'm just wondering that beautiful tag that I had there. I said to my wife the other day, I want a sleeve, and she said, just put a shirt on. So I'm talking from the perspective of someone who doesn't know anything about space. The closest I've ever got is the oscillopsia. At least that's described so beautifully by you, of what I had suffered on 2 separate occasions, including my whole going round and round in circles, each just days before the space conference. Once this week. Once induced oscillopsia. Months ago before the space clothing they had. I was overcome by this. And I diagnosed my own vestibular migraine. I call it. No idea, but I can only imagine if I were to magnify that, what the astronauts are feeling. So the thing that's always made me interested about space, and I guess it's my perspective as a surgeon, as an orthopedic surgeon, is what happens when it goes bang. Because, when you read about space, it's always the good stuff. The rockets and the lunar modules, and you spend more time on the broken leg of the Japanese lunar module than to talk about the injury of an astronaut. Makes me think maybe astronauts is part of the whole equation. I don't have no idea, but there was so that, and then when I went into PubMed to look up the knowledge base in surgery and orthopedics, it's so confined. It's less than 1 month's public orthopedic publications is for space as compared to the hundreds of thousands of other ones over the last decade. So very little knowledge is known about an area that we're all investing in. So Australia's place in space race is really at its infancy now. We have shown launch capability, and I believe we're about to send a package into space, but we only have 27 million people. Victoria has the highest death rating of all the states. You know, there is no way that we would spend any time building rockets and doing this frequent travel business. So what is our role? And I think we have a lot to offer because what we invest in is people's brain powers and thinking. So I honestly believe we have a lot to invest and give back in terms of our intellectual contribution to problem solving what happens in space. Not necessarily building the kit that goes up. So first of all, like everything else, and I guess my approach has always been driven by my surgical view of life, that there's a need for you to do anything. And there is a need. I think we understand the conditions that we might be involved with in space so clearly. And there were so many things that Fiona spoke about, Steve spoke about, that I thought, wow, you know that, right? Is that really what happens? And so what I do know, reading those very few articles, is that injury, infection, blood loss is some of the most important things that might occur out there that might lead to a mission being aborted. And that limb fracture, the risk of that in a 950-day mission, for example, is 0.05. Unlikely to happen, but together represents the fifth highest impact for mission in abortion. So it's rather important. Sort of things we are thinking and talking about are actually rather important. Secondly, what they probably don't want is us creating yet another world of discovery research, having no practical contribution, because it's the dollar value people get out of this. So I think the same thing applies to surgery. People aren't interested in the great stuff in the kit, they just want the problem fixed. And so the approach is, you know, can we be challenged to provide a practical solution? The timeline is getting shorter. I attended a leadership conference and we talked about the strategies of how we're going to make University of Melbourne Faculty of Medicine, Dentistry, Health Science, the number one in the universe. And so they said, what we want is how will it be different in 2040? And they said, by 2040, we're going to have a great curriculum. I sort of sat there and I thought, yeah, okay. What else? And someone got up and we're all going to walk around and we're all going to feel safe. 2040. Wow, what a great strategy. You know, and then they said, diversity. We believe in diversity. There were 150 people in the room. I was the only Asian. So, what the challenges? So I got up and I said, well, actually, 3 years' time, we're going to be on the moon. And on this side of the decade, they're being on the way to Mars. So let's compare those two strategic missions with safety, diversity, and better curriculum. Where each year,
And there was no Asian in the room.
After that so the timeline is actually getting shorter. The timeline has been dictated by others that we have to move on this if we are to be competitive and really exercise the brains, which I think Australia has one of the smartest people around. Because we come from all different walks of life, so it's exciting to be able to like this, you know. And I think we have a great opportunity. The reason why we have great opportunity is, unlike many other places, we collaborate really well. I have, through Gordon, learned that colleagues from Korea, Japan, who run some of the most successful programs, don't understand what it is to collaborate outside the universities. They have no concept. They feel intimidated. We have a collaboration, University of Melbourne has a collaboration with Sutton. And I learned something about the paradigm in Tokyo that makes them want to collaborate with someone in Melbourne. Right? It tells me something. We collaborate really well. Of course, we've got universities, tricky box, treacle, pies, call it what you like, but we all collaborate with this group. And so what we bring, which other people can't boast about, and which, you know, people like Gordon and Fiona are so good at sort of casting the net wide, is that we bring and we don't duplicate, we add to that. And I think any submission that we might ultimately make would immediately benefit from the fact that we're all prepared to hold hands with each other and look for the strengths that will make up each of the different sections of this endeavor. So for me, just thinking about this in space surgery, the challenges are environmental, the presence of experts, equipment, whether we answer the question, do we just stabilize, shoot them back within 24 hours, or Soyuz craft or minute, whatever, or is this meant to be definitive care? Now, if you're actually on the way to Mars, too bad, either you hang about or we hit the jettison button, but we're not turning back. You know, so we really have to be able to answer questions and target on care in that direction. And also, what happens after the care? It's not just about the care, there's the stuff that follows. And usually the stuff that follows is not at all attractive. No one knows about that. We're just interested in the glitzy surgery that we do, but in fact, there's so much else that goes through this that makes for successful care. And then to understand the knowledge gap, there's this phenomenon. Has anyone heard of SCP? Stands for someone else's problem. You know, SCP, usually when I say that, everyone goes, oh, you're on your own. So you know, we have to somehow own part of the future of what's going to be space travel. Just like it was, as I keep being told, the first Australian who designed the black box for planes. The chute that goes up inside planes was two Australians who did that. You know, and we have a part to play in all this business. So there are many similarities between injuries in space and on Earth. Astronauts will fall over, get bumped, get hit, just like elderly people on frames go over. Last night I was operating at about 10 o'clock last night on someone who was fantastic. She had a cancer in her leg. And I thought, oh my God, it's going to break. In fact, it's a little crack there. I said, so for the next 8 weeks, it's do nothing. And she did nothing. And she was so diligent as she received the therapy because the was very late diagnosis for me to get that treated first. Wouldn't believe it. The day before chemotherapy was supposed to finish, she fell out of bed. So last night we were collaring it all together. And it sort of reminds me of this, that in one of the real dire situations where you don't want something to happen, things happen. And we have falls. What do you do with these people when they fall? How do you get them to where they go? They are a high risk. And for me, in my world of orthopedics, it is osteoporosis and the physiological stresses that are immediately linked to the environments that have been described so far. The challenges to the patient that I will need is how do you actually image someone and know precisely what's going on? Because, you know, I was told by one of the people at NASA, you're only allowed to take 5 kilos of medical equipment and bits on flight. 5 kilos. That is not going to get you an X-ray machine, CT scan, no way. So how do we image people? Do we have digital twins? So on your little USB that you're allowed to take out, your entire body is there. Do we have systems within the aircraft or the spacecraft where as you move, you're being tracked, so I can tell precisely which part of you is being tracked. And because I can do that, I can match it against the digital twins where the break is. What about anesthesia? What types of anesthesia? How efficacious are they in space? And of course, this problem, and it's really interesting that the colloquium that was last July, I'm not sure if it was Boeing or somebody, you probably know, but they said, we are going to conduct an experiment to know what sort of bugs exist in the spacecraft. Wow, they went into space in 1952. It's now 2023. It's the first time they asked that question. We want to know what bugs are there in this spacecraft. So it just tells me immediately order of priority. The slightest thing that can kill you the most is thought about 70 years after the event. Isn't it? And we know that antibiotics are taken in space immediately. The really great antibiotics, gentamicin, vancomycin, etc., are deactivated by radiation just like that. So they're not useful at all. So what happens if a child is born in space? Would they have superbugs? Would they be allowed back into Earth? don't know. What do you do about pregnancy in space? Do you know what pregnancy in microgravity is? They were going to be like, what do you do? So there's so many sort of questions like that that sort of go through my mind. The other thing is the place. This is my operating theatre, it's in Vincent's. This is the operating theatre in the USS nuclear warship, the Carl Vincent, getting smaller. And, you know, we have clean air. It's cycled that many 100,000 times per minute or whatever it is. It's positive pressure. You stand at the door, you can feel the pressure. So everything's blown out, not sucked into the theatre. There's a real workflow. Anaesthetists on the other side of the blood-brain barrier, surgeons on this side. We have space. We have all that kit in there. Tons of space. No wonder surgeons feel like the king and queens of the castle. You know? But then when you go to a place like the US aircraft carrier, suddenly it gets pretty small. This is what it's like in space. This is the solution, keeping people in bed. But what if they can't be in bed? What if there's a bowel problem? What if you have to get someone up in a thoracic position? What if one of the female astronauts had a gynecological problem? How would you strap them in, as it were? You know, so we have to think about things like this as part of the challenges. The other thing is, the challenge is the team. All these people exist when I put one screw into a patient. There are only 5 people on the flight to Mars, and one of them's injured, that leaves 4. So how do we coordinate? And you can't have a specialist for each of the 10 surgical disciplines on board. So how do you actually deal with what you need to deal with? Recognizing, having said that, there's a frequency of events, most likely soft tissue, followed by bone, stuff, as it were. But nonetheless, you know, how do you the challenge of the team? Then there's my favorite bits is other bits and pieces. A lot of fun designing bits and pieces, making it out new stuff. The whole, that's just to put in the joint, which comprises 3 pieces. A tibial component, a femoral component, and a patellar component. The shin bone, the thigh bone, the patellar bone. You require a huge inventory for that. Now, if, like last night, there was someone with broken bones, just double the size of that. Remembering only about 5 kilos. That's $10,000 a kilo. $10,000 a kilo US. So there's the concept of inventory. How do we go about doing that? And to pick up on what Fiona was saying, you know, we need to be thinking about how do we make it just in time. Right? What do we do? You obviously can't 3D print any metal out there unless you do outer space. I guess in an oxygen-rich environment, really hot lasers and ion beams don't go well. So what sort of printing? You print a plate and a screw. Could you actually harvest from an astronaut their own bone, create into a screw that you put in? I don't know, those are the sorts of things to think about. Because the sorts of screws you need are going to be very different from the screws you use on Earth, because the bone is osteoporotic. I think the first signs of change is about 3 weeks. And then if you're prolonged, like people who enjoy the 1 year, this is fantastic, I'm here, it's the longest person out there, there is a permanent impact on bone physiology that's irreversible as well. So we have to start thinking different types of screws and the threads and the pitch and the width, so you're managing osteoporotic bone as we do. So 3D printed devices, things like that, bespoke implants, and how you use the digital twin system to actually map on areas becomes important. And then, of course, wound closure. I was often told the wound heals from end to end, not from side to side. So make a really big incision, Choong stuff with this small stuff, you know. But the reality is, when you're up in space, how do you close a wound? Do you stitch them and have a tiny little needle floating off into space that you can't find? It'll stick you in the eye anywhere on the clock because you lost it? No, it's an international incident. You can't find a needle after surgery. You know, X-ray machines come out and, you know, all sorts of things, and then you get bashed over their head and sign all these 10 forms and triple hit. Because people because people really worry about. So how do you close the wound? And what sort of antisepsis do you use? How do you stop bleeding? When people bleed in space, it's actually droplet form because you don't have blood flow as such. Right? It's spit blood. So where is actually bleeding coming from? Example. And what do you do to stop bleeding? How do you know when healing has occurred? How do you know when there's infection? A few years ago, I worked with some of the engineers at the University of Melbourne looking for ways of detecting infection by a sensor that you put on top of skin, for example. You know, do you go down that path? So we have to start looking at partnerships within our own ecosystems, you know, universities, industries, and our healthcare networks that we work with. Each of them providing the union of each will provide certain benefits that together hopefully will have impact on governments, international consortia, as well as regulatory agencies. Because when you're in space, there are boundaries. Under whose law do you exist or perform? So, as Fiona says, the application to earthly challenges are austere environments, resource limitations, practical solutions, and cost containment, which is precisely what we are going to do on Earth for our extreme environments. They used to laugh at me when I said, "What if the pandemic happened?" And they laugh, "Really? Because the Spanish flu was the last time." And I said, "What about war? You know, war could happen anytime." And of course, you know, climate disasters and refugee issues make for huge challenges that we're going to have to face. So the future, I think single collaborative efforts that are mission driven, even if they're not successful, the first cast of grants gives us a name that we're united behind some mission as a medical community. Small now, but large in the future. We have to be very strategic with a real focus on translation. And then with that, I have full confidence that we'll get the appropriate funding, because you know something, that's how it happens. If you look at the MRFF call that's going out for this, I reckon it's the bottom line. When I read that, how specific those things are, and the way it's a semi-competitive, right? I mean, someone's had a bit of a say, and someone's here about that. If we get the shit together, we could well have things designed behind us as well. Thanks.
Thanks, Bill. And so our last presentation, and then we'll ask our colleagues online, or we'll lose our colleagues online, and then we can have a look at Gordon's video. So Gerard.
Thanks for the invitation to take part. So not surprisingly, I'm going to stand up here and say I know nothing about I issues in space, but Gordon asked me to participate. You mentioned one of the devices that we're developing together about treating abrasions like the last place that we did a dry eye. We'll have to fix some little ulcers and treat a few infections to be easy. Little did I know how many problems people are still currently trying to address. And this was in the Las Vegas Sun, so I started off preparing a talk, and I did my little Google search, and I thought, shit, space blindness, this must be a serious thing. And it was in the authority of Las Vegas Sun. This must be a really, really important issue. And so anyways, I took it a bit more seriously. And as Stephen said, you know, this SAND syndrome is real and it's active. And it's something that does have to be addressed before we can even think about any of those issues or any more complex surgeries we might wish to do. So I'm going to talk specifically about this because in my 15 minutes, I think that we do need to understand that the space-associated neuroocular syndrome is real, and as Stephen said, there are real issues associated with that. So before we go to space, we probably do need to have some plan to deal with that. Dry eye for ophthalmologists is the most boring subject that we could possibly deal with. And so I thought, well, you know, dry eye, just put a drop in. But of course, in space, you can't put that drop in. And so I won't be talking about dry eye at all, but I will be talking about trauma and why it's important that the corneal abrasions are treated appropriately. So I'll play this video just because I think it gives you some idea about how much work is currently going on and some diagnosis for the people who are online. This is the Canadian astronaut who is about to answer a question about what is he doing up there?
It affects us a lot of different ways. It affects your bones, your muscles. But one of the ways that we're learning recently is it affects your vision. We don't understand why, but it makes some people's vision worse. And we're studying it and trying to figure it out. So we have a lot of new equipment on board just to test and understand our vision. One of the things we have is a tonometer. This is actually like a pressure gauge that you touch to your eyeball. We put drops, it's weird to put drops in your eyes with no gravity. You sort of touch the little drop thing to your eyeball. It spreads over your eye. And then one of the other astronauts will just tap the center of my eyeball really carefully about 10 times. And this lovely little tonometer will figure out the pressure inside my eyeball. That's one way to measure our eyes. Another is to look into the back of them. And so we put those drops in your eyes that dilate your eye. And then I actually put this up against my eye and plug this into a computer. And then I can look into the back of my eyeball. And there are expert doctors on the ground who are looking at my eyeball while I'm doing it. And we could take photographs and videos of the optic nerve, or at least where it comes into my eyeball, and the veins and the stuff that's inside my eye. So we can do it that way. And then also, we actually do ultrasounds of our eyeballs. And that's in order to see how our eyeballs are changing, what's going on with the optic nerves. And so we have a full ultrasound machine on board, but we don't need gel. You just put a ball of water in your eye, and then you touch the ultrasound to your eyeball, or just to the water above your eyeball, and move it back and forth. And with that, we can see our whole optic nerve. We can see the
Get the idea. So really, why are we looking at those sort of investigations in space? Because of the SAND syndrome, and trying to identify what sort of problems it's causing and why it's happening. And but the first American in space, John Glenn, he actually did take an eye chart up with him, and so he was checking his vision as he went. And I think pretty much every space shuttle, there have been experiments that have been related to the eye. But as everyone's already articulated, you know, it's one thing going up into space for a short period of time, but if we're going to go to Mars and back, then this issue of SANS is even more relevant because it's dose dependent. So the longer you spend in space, the more common, more likely that this is going to occur. Now, it used to be called, that's quite a big syndrome, but now we call it SANS, so space flight associated neuroocular syndrome. And I do have a couple of slides on the pathophysiology, but basically it's a microgravity issue, and as Stephen already articulated, it causes increased intracranial pressure. And because the intracranium is connected to the optic nerve, fluid goes down the optic nerve sheath, and it actually then causes problems, which I'll talk about in the eye itself. I've got most of the information from about 3 or 4 articles that are available on PubMed. And obviously one of them is a little bit out of date because I'm going to actually have a slide here that says no one has had permanent blindness from this sort of problem in space. And obviously there are patients who have had some issues. But the pathophysiology is uncertain. We don't actually know what's causing it. But I think that it's reasonable to say that the microgravity causes this covalent fluid shift to the head. And then that fluid, for whatever reason, is getting down through the optic nerve. And then not the orbit, it's not changing the shape of the orbit, it's changing the shape of the back of the eyeball, and there are implications to that. So as I said, it's extended exposure, but look how common it is. So this issue about the near vision being affected, what's happening is that the eyeball is being compressed, and so there is a shorter distance from the cornea to where the photoreceptors are, and that's what causes the problems with reading. But also it will cause problems with distance in certain patients. So the actual refractive error of these astronauts when they go will be relevant. And that'll be, I think, you know, there'll be some practical things that people can do on that long mission to address some of these issues. If you have a look here, that 45% of astronauts that are up in space for more than 30 days have demonstrated these eye abnormalities, okay, on the various investigations that we are performing. So a lot of risk factors for this. I won't go into them, but I do want to point out that as Fiona alluded to, nutrition it plays a role, and the serum concentration of this acid is much greater in long distance space flighting in astronauts who reported the visual symptoms. So there are nutritional issues, and that means that there are nutritional strategies for reducing this particular complication. So what do they get? They get blurred vision, distance and near. They become long-sighted, even up 1.5 diopters. So that means that, you know, if someone is, let's just say 40, and they're up in space, and they don't really have any trouble with their near vision. If they change by 1.5 diopters, it means they can't read. Okay, so there are some really, I think, straightforward potential solutions for that. But the long-term issues are the visual scotomas, that you're losing little sections of your visual field over time. The actual clinical findings are interesting. The optic discodemia you can understand because the optic nerve is connected to the brain. But they also get these things called choroidal folds, and they're actually, that's the pressure from the back of the eye, and it creates these ridges in the retina, and therefore it disturbs the vision. And it's interesting because this was a paper I wrote a number of years ago, and these are choroidal folds that were caused by pressure of a laser procedure, so pressure on the eye of a laser procedure. They look pretty much identical. You can also see here on the ultrasound that there's actually fluid between the sclera, the outer wall of the eye, and the choroid. So there's actually fluid in there that's causing this problem. So they've done a lot of diagnostic procedures pre and post flight, which are interesting. You can see here it's actually a kink in the optic nerve caused by this syndrome. So imagine your nerve is taking all of the information from your eye to the brain. It's got a kink in it. It's not ideal. And this just illustrates the short duration versus the long duration flight. You're getting more fluid here between that sclera and the choroid. And this is just another OCT image showing that the fluid here is actually pushing part of the optic nerve forward. So these are real signs, these are real problems at the back of the eye, and they do have significant issues. One of the interesting things that really surprised me is this little white thing here, the arrow sign tells you where the problem is actually what we call a cotton wool spot. And it's an infarction of the retina. So it's actually part of the retina has been killed off during this syndrome. So we saw in the video a number of different diagnostic tools you can use. I don't know how much all these things cost, but they're all handheld now. So you can get an OCT fundus camera, tonometer, which the astronaut in the video was measuring the pressure inside his eye. The pressure inside the eye doesn't really increase significantly with the actual increase in intracranial pressure, which is a little bit counterintuitive. But what can happen is that those choroidal folds, when they push the eye forward, push the back of the eye forward, can actually block off where the fluid escapes from the eyeball. And that can cause what we call an acute angle closure glaucoma. So the pressure can go from normal of 16 to 18 millimeters of mercury up to 40 to 50 millimeters of mercury. And if that is like that for a period of time, then you lose the sight and infarcts the optic nerve. So this is a potential issue, and that's why the tonometer is important. And it may be that when we're sending people for 20 months to Mars, then we're going to have a problem where that fluid is building and building and building, and then closing off the drainage tube, the drainage passage of the eye. And we're going to have a problem where we can't control that with just tablets or drops. And the way that we treat an acute angle closure glaucoma is we get a laser and we put a little hole in the iris so that the fluid can get through. So it may be that one of the things we need to be thinking about is whether or not we can have a strategy to be able to address that particular issue. Now, by having the capacity to do intra-flight imaging, whether it's an OCT or whether it's just a retinal image here, these are choroidal folds that they're identified. So if you have that device and you're doing it regularly on the astronaut, you'll be able to pick up when these changes are beginning to occur. And similarly with the autorefractor, the little device that the astronaut was using, that will tell you when you're becoming a little bit long-sighted. And then if we have a treatment for SANS, which I'll talk about briefly, then you might be able to start instituting that treatment. So I think that there are many opportunities for a group like this to be able to identify a way of helping find some solutions, or at least some other ideas about how we investigate and monitor this. This is one of them. This is Bill Morgan, who's from Western Australia, and his group. And he has basically developed a retinal photophotoplethysmographic technique. And what he's actually doing is he's looking at the variation in the venous pressure in the optic nerve, which changes and correlates directly with the intracranial pressure. So if you can get that into a handheld system, then that will be a way of monitoring whether or not this problem is occurring. There's another interesting one that this is the Polaris Dawn, which I understand will be taking off in April. And you can't actually see it, but all of the astronauts have got a contact lens on. And the contact lens is actually embedded with a strain gauge to measure how the cornea changes shape over time. I think that's really interesting, but I predict that it's not going to make much difference. And if they're thinking there's a change in the cornea, which is causing the hyperopia, I think that's extremely unlikely. Now, what about prevention and treatment? Obviously, nutrition, most soft diet, reducing the resistive exercises, which we know is a risk factor. But the one I put in here, I don't think this is actually a lower body negative pressure, which is trying to address that fluid problem, fluid mismatch. And I don't know anything about that, so I thought it was very interesting. But what this group could look at is goggles to increase the intraocular pressure. So that if we can increase the intraocular pressure, then maybe we're keeping the fluid back. It's interesting, and someone is working on that at the moment. But the problem with that is if we increase the intraocular pressure too much, then we're going to have the same problem in terms of optic nerve disease. So very briefly about wound healing, I won't go over what Fiona has talked about, but corneal abrasions are very common. And in this particular article, when they looked at the medical condition symptomatology over a long period of time, the big one was eye abrasion. So just getting a wipe of the eye. Now, how do we treat that at the moment? Well, we can treat it with antibiotics. It's very important to treat it with antibiotics. You could even use a contact lens to facilitate the healing. But if we end up with this sort of problem in space where we've had a significant infection, then we're in trouble. I can't imagine how you can do a corneal transplant in space, so you're not going to take corneas with you. And the issue of cataract, whilst I think that's relevant in the long-term eye health of the astronauts when they come back to Earth, it's not going to be an acute event. And so really when a cataract starts to develop, it really will take, in most cases, it will take a few years before it becomes clinically significant. So whilst I think that that's relevant to the astronauts,
it's a post-career.
It's a post-career thing, yeah. So I think that I only emphasise that. I just can't see how, from an ophthalmic point of view, we would be doing any of those major types of surgery. What we will be dealing with are these abrasions and possibly even something a little bit worse than that, like a penetrating eye injury. So where there's an injury which actually penetrates the eye. So this is the iFix system. This is what Gordon and I have been working on for a period of time. It's just a handheld device that basically places a bio ink in an abrasion or an ulcer. And we can make it transparent. We can actually, the actual components of it, a lot of it is human platelet lysate, but we can actually demonstrate that it accelerates the healing. So we're getting migration of the epithelial cells on the surface of the eye, and it, I won't go through the animal experiments, but we've shown a statistically different, superior result with it. But in addition to that, there are other bioinks that you can use to fill deeper holes, and this ink and a number of the other inks that we're using can actually be used to seal a hole in the eyeball. And to, I don't know how hard it is to take an ink to space, but having a device that allows you to do that in a relatively small area will allow you to manage the abrasions, to prevent infections, and potentially to deal with perforations as well. So Gordon asked me to think about what sort of research areas we should be looking at. And I think that understanding the network that Gordon has, I think that looking at some of those in-flight diagnostics is valuable. I'm intrigued by the IOP goggles that increase the pressure in the eyeball a little bit. I think that the ocular wound healing we're working on already, and dry eye, I guess eye drop delivery is relevant to, if you're going to have 30% of the astronauts getting dry eye. But a simple solution to that is simply to use an ointment rather than a drop that goes straight on. So I hope that has stimulated some ideas, but for me, it's it's been a learning experience. I thought that these problems would be simple, as a surgeon, surgical solution. But the SANS issue is relevant, and if it's as new to you as it is to me, not to Stephen, of course, then really we're going to, before we can even think about going to Mars, we need to solve that problem. So, thank you.
Well, hello, everybody. My name is Gordon Cable, coming to you from Adelaide. I'm a specialist in aerospace medicine and part-time professor in the practice of space medicine at the ANU College of Health and Medicine. I've been kindly asked to have a quick chat to you this morning about surgery in space, giving a very brief overview. So thanks to Professor Gordon Wallace for the invitation to speak. It's going to be a very high-level overview, very brief, I'm afraid, in that time. So hopefully we'll just give you a few insights to think about. So first of all, I guess we should ask, why contemplate surgery in space? Well, I think, it's clear that as we go further and deeper into space and for much longer, that problems can happen medically. And I think the modelling that NASA has been doing of the sort of medical concerns that might arise have shown that on a typical 900 to 1,000 day mission to Mars, for example, you would anticipate in a crew of 6 having at least one medical or surgical emergency. And we do know that as we start exploring Mars and even the Moon to some extent, planetary EVA comes with it a risk of trauma with the harder work and the tasks they will have to do on the surface. So there will be a need for autonomy, Earth-independent care, as opposed to the situation now where we are really reliant upon stabilise and transfer back to Earth. To date, there's really been no surgery actually done on humans in space, but lots of experiments have been done on animal models to try and demonstrate the feasibility of how that might go, particularly in microgravity. So surgical techniques that have been tried have been reasonably successful, both on the International Space Station and during parabolic flight campaigns. There are plans to have more advanced medical capabilities on future missions. To date, there's really been very little in the way of surgical capability. Certainly in the early space program, there's nothing. And the ISS currently is very rudimentary capabilities, but going forward, they're looking at more advanced capabilities, including things like endoscopic surgery with advanced imaging techniques, and certainly the ability to provide the tools, equipments, and, for example, prostheses and other implements that might be required by 3D printing. I don't think I need to remind you of this, that space is a hostile environment for humans. These are all the issues that are encountered. The radiation environment is entirely different and more hazardous. Microgravity, of course, we all recognise as being a major concern for transit in space, not so much planetary environments. Vacuum and hypobarics, the low pressure environments encountered, different breathing mixtures and oxygen concentrations. I think on that list, probably the 2 other major concerns would be the possibility of trauma requiring surgery from micrometeoroids or other space debris impacts, and the concern about the ubiquitous nature of dust on planetary surfaces, trying to maintain a sterile field with lunar regolith and Mars regolith being very, very hard to control sometimes. NASA Human Research Program categorises 5 major challenges of human spaceflight. I'm going to use these 5 on the slide here to try and discuss the surgical challenges as well, which are associated with those particular factors. Altered gravity fields is probably one of the most important, but really microgravity for surgery is the biggest concern. Surgery on planetary surfaces where there is partial gravity probably isn't so much of a problem. So in microgravity, you can see there a shot from the International Space Station trying to do CPR in microgravity, but similarly, trying to do surgery in space, things change a little bit. You have to be able to restrain the patient and all the instruments that you might need to use. The difficulty in maintaining a sterile field around the surgical wound, where you have fluids, other particulates floating in microgravity that could contaminate a wound, including microbiologicals. You've got the hazards of human body fluids escaping into that microgravity environment. Keeping the field clean and dry, hemostatically controlled. Venous ooze is certainly easier to control than arterial bleeding in that circumstance. And then the other surgical techniques that might be required, such as infusing fluids, irrigating wounds, draining body cavities, or even indwelling catheters, nasogastric tubes, and other drainage mechanisms which rely on gravity, of course, won't be present in microgravity. On a planetary surface such as Mars, 3/8 gravity, those things really shouldn't be as big an issue. Microgravity also poses some physiological challenges in the way that the body may respond to anesthetic agents as a result of fluid shifts and cardiovascular changes that occur in that environment. Anesthetic agents particularly problematic. For example, use of epidural anesthesia will not be possible, as that is a gravity-dependent procedure, as are some imaging techniques. Imaging the body under microgravity conditions means that you need to interpret the images differently. Anatomical changes also might be relevant for certain procedures if the organs have shifted around. That's a quick photo of the parabolic flight campaign, looking at a surgical field covered by an enclosure to try and maintain sterility of the field and also control any fluids that are coming out of the wound, such as blood. Isolation and confinement. There's a lot of people, well, not that many people confined in a very small space for a long time, but who you send there is important into that space. So the crew composition and the training that they have, medically or otherwise, but certainly, you'd want to send a doctor on most missions beyond the Earth-Moon system. I think that's NASA's intent. But then once they're there, how do you maintain their skills in that environment? It's not like they're going to be performing surgery every day. So maintaining surgical and emergency skills will be of importance. And if an emergency does arrive, then what is the impact on the crew, the psychological impact, and potentially the outcome of the mission may be impacted as well, the goals. In a very closed environment like spacecraft, it's a hostile closed environment. That's the European Columbus module you see there. Because it's pretty much a fully recycled environment where gases, the atmosphere is recycled, water is recycled, you cannot use volatile anesthetic agents. There's also a concern for microbiological contamination of surgical wounds. The microbes may be floating in that microgravity environment, but they do contaminate most surfaces on the ISS. And there's a wide variety of flora that have been swamped and demonstrated up there. The microbiome of humans changes as well. So the gut, the nose, the skin, all these areas of the body experience changes in the microbiology that's going on. And it is well demonstrated now that the immune system of humans changes in these isolated, hostile and closed environments, probably as a result of stress, as a result of the stress hormones, cortisol, the catecholamines, but we see changes in cellular components of the immune system, as well as the humoral elements such as cytokines. And hygiene in microgravity is very, very difficult. There's no flowing water. As you know, astronauts can't shower, so maintaining the cleanliness of patients post-operatively, hygiene would be somewhat restricted. As we go further from Earth, resupply becomes very limited. So you're in a very much a resource-constrained environment. So how do you know what to take with you to cater for different contingencies you might encounter? That needs to be modelled before we go, and there are modelling tools to do that. But we also have to be aware of the communications latency. The autonomy is important. You are not going to get the sort of support from the ground through telemedicine necessarily that you would want, through surgeons on the ground who can advise and so on. So in terms of the crew size and composition and the training, that is really important. You need to have people trained sufficiently to have autonomous operations essentially in this remote environment. Also because of the distance and because of the constrained limitations in terms of what you can take with you, mass, volume and power become important considerations. You may not be able to take all the equipment that you need. And then how reliable is that equipment? What if medical equipment fails on you and it's no longer available with no redundancy? So really a fundamental question is, is intensive care support, post-operative care even feasible in a space environment versus evacuation back to Earth? Imaging on the ISS currently is ultrasound only, and that's unlikely to change. And you can see there that the ISS ultrasound machine, quite small and compact, but for deep space missions, equally, it needs to be very small, compact imaging. Finally, radiation. The main concerns there are the stability and shelf life of the drugs that we use for treatment of patients in emergencies or for anesthetics. We do know that antibiotics, for example, have reduced efficacy after exposure to space radiation. And we think radiation also plays a role in the immune system dysfunction that we experience. Enablers could potentially be, of course, the selection of appropriate crew and their training, making sure that any physicians on board have extended surgical and anaesthetic skills. Telehealth may help to some extent, but the further you go, the more limited that will become. There have been experiments looking at cryogenic preservation of of pharmaceuticals, for example. It's really difficult to pre-deploy supplies to Mars because that needs to be done probably 2 years in advance of the cruise. So this shelf life and preservation of medications and other supplies, food as well, for example, becomes really critical. And then finally, how can technology help us? So artificial intelligence, robotics, 3D printing, additive manufacturing, or synthetic biology are all being looked at as mechanisms to produce what you need when you need it, or to aid the crew in the techniques that might be used surgically. So there's some further reading for you. I'm going to end there. I hope I didn't go longer than my 10 minutes. It's been a very brief overview, but hopefully gets you thinking about some of the aspects of your own surgical specialties in space as you go through the discussions today. So thanks for the invitation to speak. I hope you have a successful meeting, and I look forward to perhaps meeting you all and discussing things in more detail at some time in the future. Thanks, and bye for now.